Hi everybody, my name's Jo Gibson. I'm a clinical physiotherapy specialist working at the Liverpool Upper Limb Unit in Liverpool at the UK, and I'm also a consultant in private practice. Now, those of you who joined us last Monday will know that we talked about a very specific case study, a young swimmer who came with what seemed to be an overuse injury in their shoulder, and we talked about some of the key hints, tips and tricks about acromial apophylysis. So that was our kind of discussion point last time. And we had a discussion about how perhaps we could differentiate that from distal clavicular osteolysis. We talked about some of the risk factors in terms of training overload, laxity, and growth spurts. And I said I'd pop back again this Monday just to talk about perhaps another traumatic injury that you might want to discuss in a consider in a pediatric population, but also then to consider that overuse pathology and the relevance of the skeletally immature athlete, and certainly in terms of growth plates. So in terms of just finishing off what we were talking about, the acromium last time and the AC joint particularly, you'll remember we said that we can get that apophylysis or that irritation, if you like, due to overuse of those different parts of the acromion before it's fused. But we also talked about this distal clavicle osteolysis that we can see in children, and we can also see in our skeletally mature populations. And we talked about that weightlifters, people regularly bench pressing over 1.5 times their body weight, if that's their 1 repetition max, but also people who've had a contact injury to the shoulder or anything on an outstretched shoulder, again, if they go back to loading too quickly, are at risk of developing an osteolysis. So it's something we should always consider in terms of our differential diagnosis in somebody that's got ongoing shoulder pain, which they locate to the AC joint region, and particularly if the pattern is every time they go back to loaded activity, particularly overhead or any sort of bench press. Now, in terms of considering that trauma, I saw again a gymnast who'd been training. They were 13 years old. They'd had a fall when they were doing a vault and they'd landed on an outstretched hand. Now, when they described their mechanism of injury, it was fairly much the arm was out in front of them. It wasn't across the body or anything else, but they had a real bump over the lateral end of their clavicle and had been told by the GP that they thought they had a type 2 AC joint sprain. So they came to me because they had pain at end range, pain on cross adduction, couldn't lie on the shoulder at night, and pain wasn't particularly settling. Now, in terms of our typical AC joint instability type injuries, we know we have our Rockwood classification in terms of types 1 to 5. So the things in my head that I'm considering in terms of the mechanism of injury are either just a sprain to those AC joint ligaments, so a type 1 injury, an actual tear, or if you like, some actual damage to those AC joint ligaments, a type 2, a type 3 injury, which is when we get damage of both the AC joint ligaments and the coracoclavicular ligaments, and then a type 4 and a type 5 and 6, which really just represent increasing damage and involvement of the deltoid trapezial fascia that attaches and helps stabilize through those attachments. And essentially they're dictated into what direction the clavicle goes. So whether it goes posteriorly in a type 4, superiorly in a type 5, or inferiorly behind the conjoined tendon in a type 6. Now, we've got all sorts of, if you like, interest in this classification system and how that should direct treatment. But as ever, with many things in shoulder world, we're starting to see that there are actually some limitations. If you look at diagnosis based on X-ray, then actually when you compare it with MRI or CT, then certainly in MRI studies, they don't agree in about 50% of cases. Jane, thank you. We're already getting some questions, which is awesome, and I promise I'll come back to those at the end. But in terms of this classification system, very much treatment has been based on that, with the belief that in a type 1 or 2, they should have physiotherapy, a type 3, the jury's still out, and you should probably trial conservative management first, and then those 4, 5, and 6 with more damage to the soft tissues need surgery. Now, what's interesting is when you look at surgical papers, that's really being challenged in terms of it's much more about the patient's symptoms and whether they can cope or not than just basing it on the scan. Certainly, I had a goalkeeper fairly recently who, again, had a scan, from the description on the scan, it sounded like he had a type 3 injury, where normally you would look at a 6 to 12 week return to sport. He was back playing with no symptoms at 3 weeks. So again, it's very much about our clinical picture rather than just basing it on imaging. And when we look at those MRI studies that disagree with X-ray diagnosis, then actually what's interesting is they overestimate the severity as well as underestimate it. So again, it's just being a little bit cautious. Now, back to our 13-year-old gymnast. Why have I shared that with you? That sounds quite straightforward. Well, as we mentioned last time, we can have two different types of mechanism for AC joint instability injuries. We can have a direct injury where somebody falls with the arm in cross adduction and hits the point of the shoulder, so takes the acromion away, or we can have that indirect mechanism where we fall onto an outstretched hand, which sounds fairly typical here. The confounder in somebody that's 13 is that they've potentially still got their growth plate at the distal end of the clavicle. Now, interestingly, the weakest growth plate in the clavicle is the medial one, and so that's the one that's most commonly injured. However, when we look at the relative strength of the growth plate compared to the AC joint ligaments and the muscles that attach across there, if you have a young person with an apparent deformity or bump or just tenderness after that sort of injury, we just need to be a little bit cautious, because you can get what appears like a pseudo subluxation because of an injury to that growth plate rather than the AC joint itself. Now, clearly, all the same provocation tests are likely to cause symptoms, but that's why your imaging is very important, particularly in somebody whose symptoms aren't settling. You generally expect a soft tissue injury or type 1 or 2 sprain to improve quite significantly over a 3 to 6 week period, just with mobilization and general management. However, if symptoms are persisting, and particularly if everything is aggravated by load, we want to have quite a low threshold in these younger athletes, particularly if they're going back to sport, to actually do some imaging to make sure that actually it isn't an injury of the growth plate. Why is that important? Well, again, generally these things do very well with conservative management, but in terms of displacement, it's important to know the severity of that injury, really to highlight management choices. So in our younger athletes, it's perhaps our imaging is a little bit more relevant, perhaps compared to those clinical symptoms, than perhaps in our skeletally mature. Now, what's also really interesting when we look at those type of fractures, what's interesting is as long as younger patients are kind of they've got another 2 years of growing, if you like, before they're skeletally mature, then actually they tend to do very well because of the amazing remodeling potential, if you like, of those types of fractures. The only things we have to be aware of is obviously the pull of the muscles around that system. But those lateral, those clavicle epiphyseal injuries are incredibly rare. But it was just one to mention, again, thinking of completing what we talked about, those traumatic AC joint injuries. Now, the other thing that I wanted to share with you, because we had such a nice discussion about those apophylysis type injuries and those overuse injuries in our younger athletes, is something that relates to the humeral epiphysis. Now, one of the questions last week was, can you get a slipped epiphysis in the proximal humerus? And the answer is absolutely. You can get it as a response to trauma, to a traction injury. But interestingly, for poor kids that have had primary bone cancers like a Ewing sarcoma, we also have reports of a slipped epiphysis in the proximal humerus following radiotherapy. So again, pretty tough going when they've already got that to deal with, but something else to bear in mind. Now, when we look at physical injuries, so the growth plate and things that might involve that, there is a classification known as the Salter-Harris classification, which essentially the most popular version splits into 5 different subgroups of types of fractures. And essentially, Salter, if you like, is an acronym to help you remember the different types of fractures. Now, the most common are type 1 and 2. So S stands for slipped or separated, so a widening, a slip, a separation, if you like, of the epiphysis from the growth plate. You have your A, which is above, which is your type 2. And that's where, if you look at, it's slightly difficult in the shoulder, because if you look at all the classifications, they often show you the femoral condyle. So your metaphysis is on top and your epiphysis is on the bottom. Whereas obviously at the top of the humerus, it's the other way round. You've got the epiphysis, you've got your growth plate, you've got your metaphysis, which obviously includes that growth plate, that physis. So with these physical injuries, the Salter-Harris really dictates where it is in relation to the growth plate. So as I say, the type 1 is that separation or that slip. The type 2 is where actually it's kind of involves the metaphysis. The type 3 is when it involves the epiphysis. So as you can imagine, if it was at the bottom of the humerus, then it would be A would be above. Unfortunately, the shoulder doesn't follow that, and L is for lower or below. And then we have the TE in Salter, which is the through everything, where basically the fracture goes through the growth plate, the epiphysis, and the metaphysis. And then you have a very rare, which is the R in Salter, which stands for rammed or crushed, where essentially it's like a compression injury. Now, in terms of having an impact on growth, then it's that type 5 that has the most profound effects, potentially arresting growth in the humerus. Now, the growth plate in the proximal humerus is actually responsible for about 80% of the growth of the length, if you like, of the humeral bone. So it is really important, and that's why picking up some of these injuries is important. Now, clearly, if an athlete comes to you with a history of trauma and some lateral humerus pain and, describes a kind of mechanism of injury, then of course we're going to investigate. But MRI is really important when you are evaluating paediatric traumatic injuries, because often you can make false diagnosis or incorrect diagnosis based on a plain X-ray. Why? Well, again, when we look as a younger cohort, what's interesting is we can actually use age as an early clue, if you like, as to what the problem's likely to be. If you look at those type 1 Salter-Harris injuries, where you get a slip or separation of that epiphysis, then generally that's in a really young population under the age of 5. However, when you look at the type 2, when you've got that involvement of the metaphysis, then that's an age group over the age of 12. So in terms of fractures, then age really does seem to have an impact on where the relative area of give is. Now, it's interesting because if you look at another condition that can cause widening of that humerus epiphysis, that humeral physis or growth plate, so we see widening, is a thing called little leaguer's shoulder. Now, little leaguers, no great surprise, it comes from baseball, but essentially it's something to be aware of in our throwing populations. Now, I've seen two guys with this who were both around 12, and what's really interesting, this little leaguer's shoulder, as I say, there is a little leaguer's elbow as well, but essentially this little leaguer's shoulder just relates to widening due to stress and overuse caused by throwing. Now, when they've looked at the key times that this happens, it's very consistent with what we talked about last week. It's definitely related to load, and it's definitely related to growth spurts. So if you remember, we said that our male young athletes tend to skeletally mature later than our female athletes. And that's quite significant because, again, when you look at the average age of patients who present with this little leaguer's or this humeral epiphylysis, to give it its posh name, essentially where you've just got irritation of the growth plate because of this overload, then the average age is around 14. Now, again, really the key message, very much like we discussed last week, was that the problem is often these kids get pain, it's put down to growing pain, they keep on training, they're reluctant to miss out on anything. But it's key to know that actually when you look at outcomes of these patients, the ones who do well are the ones where it's picked up quickly, they have a period of rest anywhere between 4 to 8 weeks, and then gradually increase their throwing again. The ones who have poorer outcomes is the ones who have a much longer time before they're actually investigated and they're actually given the diagnosis and then have an enforced period of rest, and they're the ones who are more likely to have recurrence. Now, interestingly, there's quite a high correlation with this little eagle's shoulder, and then having more marked humeral retroversion. So that's kind of bony adaptation to stresses, which again seems to have some relevance in relative risk of injury in later life. So again, it shows you the responsibility we have. These issues are relatively rare. They don't happen a lot, but when they do happen, they're the key thing that would differentiate somebody with this little eagle's shoulder, where again they'll have tenderness in that lateral humerus, is it's a gradual onset of pain. 91% of people give a clear history where essentially they have had just a gradual, they've been throwing for a long period of time. So something to bear in mind. Now, interestingly, the other thing that correlated with poor outcomes, as well as that longer time to when they were investigated or started having some sort of intervention, was a loss of flexibility. And that was very much measured by both external rotation and looking at GERD relative to the other shoulder. Now, GERD's an interesting one because again, everybody gets all excited, but it does seem to give us an indication in the absence of any capsular component of posterior cuff fatigue. So muscles tired, rest in its shortened position. Now that's relevant because a nice review that's come out recently by Salam et al. 2020 actually looked at risk factors in baseball pitchers particularly, and actually showed that arm fatigue and flexibility did seem to be risk factors, but arm fatigue was the biggest. How can we measure that? By monitoring changes in this GERD. So again, some very simple things that help us apply and perhaps put the picture together with somebody who comes with lateral humeral pain. Now, as I say, many of these things have a genetic predisposition. What's interesting in this little leaguer's shoulder is there doesn't seem to be any major link with laxity, but as I say, there is a key link with growth spurts. So again, it just makes us to be vigilant. Sharing these particular case studies with you, or some of the kind of less common pathologies that we see, is just so they're there in your mind if you happen to see a young athlete who's got shoulder pain. If it's a gradual onset, do we need to do something? Does it sound like it could be a growth plate injury? We need to know an MRI is therefore your friend, because it will differentiate between fracture and an overuse injury, but importantly, it's knowing whether we need to enforce a period of rest. Again, when you look at the humeral epiphysis, the bottom line is that if you don't give them a period of rest, you just modify their throwing, they don't seem to do as well, and they've got a higher chance of recurrence than those who have a complete break. And we know how hard that is with our young athletes. Now, we talked about swimmers last time, very similar thing. And again, one of the questions that came up was about load. And no great surprise, I'm just trying to remember the author off the top of my head. I'll post it in the link to the Facebook. But again, showing that training load and amount of competition and fixture congestion again was a big risk factor. So we're seeing we all know this, guys. We know that in young athletes, particularly if they're having a growth spurt, then they're more at risk at having some of these injuries. So just, if you've got somebody who's a throwing athlete, gradual onset of lateral shoulder pain, hurts when you press it, hasn't done any particular rest, has been throwing for a long period of time, just bear in mind that little leaguer's shoulder. And similarly, in terms of trauma, if you have somebody who presents with a direct or indirect injury to their AC joint acromion, then just bear in mind, is it actually the epiphysis or the physical plate that's involved, not the actual AC joint itself? Why is it important? Just in terms of monitoring, but also in terms of load management and potentially opening up different treatment options. The great thing with our young athletes is they've got such huge potential in terms of humeral remodeling. As long as I say they've got about another 2 years to go before they're actually skeletally mature. And when we look at those growth plates, both in the humerus and the clavicle, they're actually quite late to close. So generally that gives our patients a little bit more leeway. Now, guys, there's all sorts of great questions here. So Jane, following last week's talk on weightlifters and osteolysis, do you routinely check for brachial DVTs in this group? Do you think the rate of brachial DVTs will increase, follow the trend of restricted blood flow? Wow, Jane, that's a really interesting question. I guess the answer is I look for brachial DVTs if they've got a sign, but also in terms of their descriptors of their symptoms and stuff. In terms of, I think it comes back to what I said last time, in terms of my clinical picture fitting, in terms of where their symptoms are, what provokes their symptoms, obviously whether they've got any peripheral symptoms, and also more of a vascular pattern or But that's a really good one. I might have to look at that and make that a subject of a future Facebook. So thank you for that question. I guess the answer is no, I don't routinely check, but it would definitely be part of my differential diagnosis in somebody who had signs that made me think there was perhaps more of a vascular involvement. So thank you very much for that question. That was a goodie. Mina, you purchased my course. Thank you very much. That's amazing. I'm glad you're enjoying it. That's awesome. How about posterior capsular tightness in rotator cuff tendon problem, if truly capsular problem? So this ties in really nicely with what I was just just mentioning in terms of our GERD. Okay, the bottom line is, for years and years and years, there were loads of papers came out of the American literature saying to us that people who had shoulder pain had a positive GERD. So if you compared their internal rotation in 90 from side to side, then there would be a deficit of 20 degrees or greater, and that correlated with shoulder pain. And we then had some studies that showed if you did an intervention and that got better over a period of time, it correlated with symptoms going away. Now, the issue was there were also some studies that suggested it was a potential risk factor, particularly in combination with increases in loads in athletic populations. And again, a lot of that research came from throwing athletes and a lot of it from baseball pitchers. Now, that picture of GERD in itself just being a standalone risk factor is still contested. But the important thing is, in all those athletes who were throwing athletes who has a positive GERD, when they did arthroscopy to evaluate the capsule, there was no evidence of any fibrosis or change in the capsule itself. So the only patients they found any evidence of that were elite throwers at the end of their throwing career. So what does that tell us? Well, very like some of the discussions we've had on here previously about differentiating between true frozen shoulder and muscle stiffness, we see exactly the same thing in the back of the shoulder. If somebody fatigues their posterior cuff, they will get stiffer because the muscle rests in its shortened position. So what we do see is that actually this can be a nice some more questions. This is getting interesting. If you have a patient who is relative stiff and you do some sort of facilitation or you do some massage and it gets better, it's just muscle stiffness. Now, the only thing to be aware of, and it ties in very nicely with that throwing population that we were talking about, is this concept of humeral retroversion, which I mentioned. Humeral retroversion relates both from genetic factors, but also from bony adaptation to stress. So if an athlete has thrown from a young age, and I mean a very young age, and has thrown consistently, they have a much higher chance of developing humeral retroversion. And remember, if they get little Liger's shoulder, even more likely. Now, why is that relevant? Because again, if you're looking at an athletic population and they have an apparent GERD, it's really important to look at their total range of movement and compare it side to side. If the total range is the same, then that would suggest that you probably have just got a shift of their rotation and you have some retroversion. Now, there's lots of different ways of measuring humeral retroversion. There's a biceps forearm angle test where essentially you're meant to palpate the tuberosities either side of the bicephal groove and then measure that looking downwards relative to the angle of the forearm. There is a paper that shows some intertester reliability, but when we look at palpation accuracy, I think maybe we need some bigger studies to prove that. Mike Reinhold and Kevin Wilkes discuss a technique where basically the patient's in supine and they just take them gently into cross adduction and see how much external rotation there is, what the resting position is. So you're not stretching, you're just going to the first point of resistance, and again you compare side to side. Now, to my knowledge, they haven't validated that test yet, but I know clinically they find that really useful. How relevant is it? Well, again, it just seems to be a factor in terms of monitoring. Do we get a change? Do we start to lose range? So for me, GERD generally is just a measure of cuff fatigue, or the fact that cuff's not coping with what it's being asked to do. So it can be a very nice, easy on-field measure in people going back to play or activity. They do their training session. Has this stiffened up? If we just do a quick bit of switch on, is it better? Great. If it's not, then I might monitor their training. So, but it very rarely reflects a true capsular component unless somebody's post-op, post-frozen shoulder, post-trauma, or in some of your endurance or real kind of big weightlifting guys who can get some selective thickening and stiffness in the posterior superior capsule, which is where they'll have more restriction of internal rotation in neutral. So for me, if I'm looking at somebody with a positive GERD, I'll always look at rotation down here first, and that will, and again, their subjective history will target which of those it's likely to be. Rob Whiteley talks that it could be protective, in that the posterior muscles are protecting. And there was a lovely viewpoint in the Journal of Orthopedic Sports and Physical Therapy by Kevin Hall that talks about some of those dilemmas about GERD, and I'll post those. In fact, there's a new paper that I just picked up today when I was preparing this, so I'll put a link to that as well. Nikki, great question. So should GERD be equal even though they're one arm dominant? Absolutely not. Now, the problem is we see an increase in GERD over time, and the problem is we don't know at what point it becomes pathological, and that's why, in conjunction with other factors like changes in load, the demands of that particular sport, because what's important about your question is if we follow rugby players, if we follow throwers, they do get adaptations over time, both in scapular symmetry and in their GERD. So, of course, that's a really important question. The issue is change in a season seems to have some relevance. So as I say, that's why it can have some use in our clinical practice. Tim, do you ever mention the word impingement for patients, or is it a phrase that you avoid? So Tim, again, we've got this great rhetoric at the moment that we want to avoid talking about impingement because it can be fear-inducing for some patients, and because it probably doesn't reflect what we understand about the underlying pathology. The traditional model where we were brought up on, you lost out on the genetic lottery, you were born with a certain shaped acromion, you developed this spur which impinged on your cuff, has really been challenged, and now it's more of a bottom-up model, or the size of whatever's in that space. However, I guess my politician's answer to you is I always ask the patient what they've already been told and then ask them what that means to them. So if a patient comes to me and says, well, my GP's told me I've got subacromial impingement, my next question is, well, what does that mean to you? If they say, well, it means I need some physio to get my muscles going, then, you know, if they're happy with that label and it's set out a path of care, why would I change it if it's got a positive context? If you ask me what my favorite descriptor is, I don't use impingement as a descriptor, if you like, when I'm explaining somebody's pain. So I think, but I think that's an important differentiation. For me, it's not a term I use to describe the cause of somebody's shoulder pain, but if they've been told it before, the important thing is what it means to them. If it's positive and they know physio's the answer, great. If they think they've got a bit of bone sticking into their rotator cuff, then that's going to be a very different conversation. So thanks for that question, because it's very, very topical. So Nikki says, would you include young tennis players with this group of young throwers because of serving? Yes, absolutely. So basically any overhead athlete, you can apply many of these theories to. The little leaguer's shoulder is most reported in baseball pitchers, for sure, and the two I've seen were in baseball pitchers, but I've certainly seen overuse growth plate, the apophylysis that we talked about last week, in tennis players, and I've certainly seen a tennis player who fell over who had a Salter type 2. So yes, absolutely, you can apply all these things. So we've talked about whether it should be equal or not. Guys, fantastic questions. Thank you very much indeed. I'm definitely going to have to do some, have a thing to come back in terms of when I'd be thinking about brachial DVTs. So thank you for that question, because you definitely got me thinking with that. I have seen a few vascular issues with patients, not very often, I'm delighted to say, and one of them was a brachial DVT, interestingly. But I think we've had GERD, we've talked about impingement, we've talked about asymmetry and how it can be normal, but that's why in these days where everybody's saying, oh, should we screen, shouldn't we? Those baseline measures are so useful just to be able to measure change. So to me, they're still an important thing in our practice. So guys, we've continued our journey through the paediatric shoulder. I'm just checking that I'd answered the questions from last time. Oh, there was one last question from last time. There was a question asking, can you get osteolysis of the whole scapula? And the answer is, yes, you can. Now, I have to say, I've never seen it ever. But apparently there's also a condition called Gorham's disease, which again can present as osteolysis of the scapula and the humerus together. Very bizarre. But what's generally shown in the literature, it's really important that patients who present with that on X-ray are fully investigated, because it can also be confused with certain primary bone cancers and metastatic disease. But in answer to your question, yes, you can get osteolysis of the whole scapula. And there's some really weird conditions that can predispose it. But as I say, Gorham's disease seems to be one of the most reported. But like many things that are weird and wonderful, it's often only reached as a diagnosis once everything else has been ruled out. So guys, thank you so much for joining. Catherine, you're welcome. I hope I answered your slipped epiphysis question. I can't remember whose was the question about the osteolysis of the scapula, but I hope I've answered that as well. To those of you who've posted questions down the sides, thank you very much indeed. Lucinda's just got in there with a last minute question before I wrap this up. If you don't use impingement as a choice and the patient had no other description from a therapist, how do you describe it? Do you go for a functional approach? So Lucinda, again, I think the thing is, I don't have a stock explanation. It's generally something around, we need to get your muscles doing their job better, or get your muscles stronger, or change the way you're moving. Or the big thing is, as part of my assessment, is that essentially I use symptom modification. So that, if you like, that gives the patient a confidence, if I've been able to change their pain, that they can move differently just by changing how the muscles are working. So generally my description is, I have to be honest, because we don't actually know what the cause of shoulder pain is. We don't know what the structure is. But generally I will say to them, look, we showed you by getting your muscles working differently, we can actually change your pain. So we just need to make that normal for you. So sometimes I'll say things like, we need to remind your muscles to do their job properly. It will depend, because again, you'll know if you've joined us on any of these before, that when we look at the bigger biopsychosocial thing, it might be they've got stress at work, it might be they do no exercise, it could be lots of other things. So generally what I will have done is sum up all the things we've talked about, and often with that kind of biopsychosocial background or a bucket of capacity, whatever I'm using on that day, and I put in all the things that can influence somebody's pain. And so if you like, my summary explanation is, look, your muscles aren't doing their job properly. This is something that gets called subacromial pain, rotator cuff related pain. It's got lots of terms, but the good news is, if we get your muscles doing their job differently, or we just give them more capacity, again, what fits in with that patient's model, then essentially that's what I'll use as my basis. So I really listen to the patient's language. I really listen to what their thoughts are, because often they'll have been on Professor Google or what a trusted friend or whoever. And if I know those things, I know it will sound hard to believe, but I use as few words as possible just to put a positive spin on it. So again, it's contextualizing it in a way that's relevant to the patient. If they come up with a metaphor of their own, I know I've got them. I have some favorite metaphors, but essentially I just keep it simple. And do they need to know more? So I feel like I've done a right politician's answer there, but it does vary according to what patients tell me. Thank you. Thanks, guys. That's awesome. So some fantastic questions. It might be good, actually. I might, in one of our future Facebook Lives, I might talk about the whole language thing again and share with you some of the metaphors I use, because I know it can be really tough. And certainly one of the exercises I quite often do when I'm teaching my 2-day course is kind of get people, how do you explain frozen shoulder? How do you explain shoulder pain? Because it is really tough. So maybe that's something we can come back to on another session. As ever, I've gone over my half an hour. Thanks so much for joining us. I really hope you've enjoyed it. Catherine, you'll have to join which one and share some of your metaphors with us. That would be awesome. It's all great to learn from each other. But for now, guys, thanks so much for joining. I hope you've taken, as ever, some useful clinical tips and tricks. For one of you out there, you'll pick up that patient with the little leaguer's shoulder, or that the physical injury in the clavicle. And that's what it's all about, is sharing knowledge so we can do the best for our patients. So thanks again for joining. And I will look forward to seeing you all next Monday for our next Facebook Live at 7 o'clock. See you then.